Dear friends, welcome, and thank you for being here together with us today. Is the European Society of Gynecology have organized a fantastic debate because we have not only the possibility to present and to discuss scientific data, but also to make a balance the clinical experience of the masters that we have in Europe. Today, we will discuss, should all pregnancy be induced at 39th week? It is a fantastic question, full of science before, full of science after, and it's not easy to maintain, to achieve the position. And then I have asked to Professor Yves Ville and Professor Gerard Visser to discuss about it. As you know, one, Professor Yves Ville will be pro, one, Gerard Visser will be against. And no, okay, we will see, we will hear later on. And I will start to ask Professor Yves. Professor Yves is Professor of Gynecology and Natural Obstetrics, Head of Obstetrics and Fetal Medicine Department at Necker Children's Hospital in Paris, Paris Cité University, member of the National Academy of Medicine, Director of EHU 7328 Pact associated with the Institut Imagine, Head of the Obstetrics and Fetal Medicine Department. And Yves, please, you can start if you want to share the screen and make your point of vision.
Thank you, Andrea. So I will show you that pregnancy has become much shorter than it used to be, and that elective induction at between 39 and 39 plus 4 weeks of gestation is beneficial to women, neonates, and infants compared to not inducing and letting the pregnancy go on. The very first example of induction of labor happened in Cyprus. And you can see here the birth of Adonis. Mira, his mother, was transformed into a myrrh tree under the bewitchment of Aphrodite, and Aphrodite made her sleep with her father, and her father went after his daughter to kill her because of that, and she was transformed by the gods into a myrrh tree and was bearing Adonis, the most beautiful child ever born. And induction was actually provoked by a wild boar bumping into the tree. So be reassured that methods have changed, but the most beautiful and healthy children are still born by induction at 39 weeks. And the discussion around that, it is established through a paradox and a strong rationale. The paradox is that every single aspect of reproductive medicine has been challenged over the last half century, except the duration of pregnancy, and that is completely illogical and incomprehensible. And going through the most advanced technique in order to get pregnant cannot be just an addition to what physiology was 100 years ago. And the rationale for that is that it is now very well established that the placenta is aging much more quickly than the fetus, and that 3 per 1,000 pregnancies end up in intrauterine fetal death after 37 weeks, which is the largest part of the intrauterine fetal death, just because the fetus at term needs oxygen much more than food. Also, the concept of a low-risk pregnancy has become a self-prophecy. No one in the world is able to triage properly which pregnancies are at low risk and which pregnancies are at higher risk. Then maternal choice prevails, but not midwife's choice, not obstetrician choice either, I agree. And all the explanation should be provided for women to make their own choice about the mode and the time of delivery, but this should not rely on lies and what midwives know better than women about their own pregnancy. And finally, organization is a key word, and all these factors concur in order to suppress the last wagon of the train of the pregnancy. And we all know that the most dangerous place in a train to be in a train crash is the last car. Unfortunately, if you remove the last car of a train, it doesn't change anything, but for pregnancy, it does. And it removes most of the accidents of the end of the pregnancy. And also, we should even look back at what has been established for so many years. At first was dating of the pregnancy. And at first it was dated on LMP. Since then, we know that half of the time women locate their LMP in the middle of the month, and that ovulation is not related to LMP with up to 14 days difference. And in a very small but beautiful study published in Human Reproduction 10 years ago, we could see that the duration of a pregnancy, the average duration was 38 weeks and a bit, 268 days and not 280 days, which by the way is 40 weeks and not 42, even less 43 weeks. And we get very close to this when the date of confinement is defined by cron lump length at 12 weeks rather than by LMP. And considering for so many years that when only 2 or 3% of women have not yet delivered is still physiology, is so horrendously contradictory to everything we learn in medicine. And just because it is pregnancy and we should keep our brain and not only hands off these women, we ended up with this disastrous belief that 43 weeks was nearly still physiology. Also, since now more than 20 years, with a beautiful study by the group from Cambridge, we know that first trimester growth restriction is not a myth. It is a reality. It is quite prevalent. And therefore, even by measuring the cron lump length, we could overlook early growth restriction. We should concur to make the pregnancy overall too long. Now, it's an allusion to my opponent, dear Jerry. You know this portrait, Jerry, from the Rijksmuseum with the Vestager sons. Jan and Simon are the oldest, and the young Heldrick is absolutely huge. Is bigger than his 2 brothers. Is probably the result of a already obstetrical large movement in Holland, pushing the pregnancy much further for this one than the previous 2. Unfortunately, this baby died in the first year. Physiology is changing. We need to absorb that. We need to think about this, and we need to apply this in our practice. Women have become pregnant women have become older. Their BMI has increased. Paternal age as well as maternal age has increased. The environment is not benign. Multiple pregnancy and assisted reproduction are more than 5% of all pregnancies. And therefore, we also discover previous histories that are relevant in their gynecological previous history. So we need to include this in our way of thinking. And one big failure of obstetrics and perinatal medicine is that we are stagnating with about 1 baby out of 200 over 22 weeks of gestation that is born dead, stillborn. And even more frustrating, the majority of those die after 37 weeks with a prevalence of up to 3 in 1,000 after 37 weeks. Maternal age is increasing, which is a good thing because it goes along with maternal choice. But these women are more exposed to all obstetrical complications, including preeclampsia, including diabetes, but then translating for the fetus and the neonate in a higher risk of perinatal death. And you can see that we go from an odd ratio of, when you take 25-year-old women as a landmark, you go from 1.2 up to threefold increase at the age of 40 and other of perinatal death, mainly intrauterine death. Paternal age has not been kept out of this, and more recently, we've also seen that increase in paternal age from 45 years old onwards would also increase the risk of stillbirth, preterm birth, and perinatal death. Obesity and more broadly body mass index in between excess and obesity, between 30 and 35, is an epidemic. And it is related to perinatal disasters, both mechanical, but also perinatal death, including intrauterine death. Hyperglycemia, even without gestational diabetes, very often correlated with maternal BMI, but not always, is a continuum of an increase of perinatal risk during the pregnancy, and it is jumping up towards the end of the pregnancy. Assisted conception, 5% of all pregnancies, especially in high-income countries such as in Europe, and all types of perinatal complications and maternal obstetric complications culminating toward the end of a pregnancy. You know, this beautiful theory illustrated by the FMF, by Kypros Nicolaides and Dr. Wright, that shows that if the pregnancy is long enough, all women are going to develop preeclampsia and the potential dramatic complication of preeclampsia, and that is completely related to the duration of the pregnancy. We also know that even when a good news for the next pregnancy happens, like a spontaneous pregnancy after infertility, these spontaneous pregnancies after a previous infertility are associated with exactly the same risk as for infertile treated couples. And more troubling even is that the risk of stillbirth, preterm delivery, growth restriction that happened in the previous pregnancy, those three types of complications are completely interchangeable for the next pregnancy. So stillbirth could end up in preterm delivery could end up in stillbirth or growth restriction, and vice versa. So very difficult to identify good news and low-risk pregnancy. Why? Because probably there is a substrate behind that, especially with two gynecological problems that have been more recently highlighted as very important quantitatively and qualitatively. One of them is polycystic ovary syndrome, up to 10% of all women. And the classic phenotype is not really that prevalent to recognize it, but it is the source of the majority of dysovulation. And there is a link with increased BMI and obesity, and therefore PCO is on the rise and not on the fall. And it is associated with all types of perinatal complications, both for mothers and especially for neonates or fetuses towards term. Same goes with endometriosis. Endometriosis, up to 15% of all women. And, you know, painful periods and things are not far from this all identified in relation with endometriosis. We find more and more of those because this has become a very important cause, a national cause in many countries to help women in this pain. It starts very early, as then this woman that you see pregnant was herself a fetus with a chronic pelvic inflammation. This inflammation is not entirely calmed and erased during the pregnancy. It is decreased, but not erased. And therefore, this chronic inflammation is in large part responsible or co-responsible for all kinds of perinatal complication, again, culminating with preeclampsia, cholestasis, and the risk of preterm prom, and the risk of perinatal complications such as stillbirth with a 30% increase in neonatal death. So the risk of expectant management in term pregnancies, if pregnancy was ending at 38 to 39, in low-risk pregnancies, and at 35 and 36 weeks in high-risk pregnancies, we would decrease the risk of stillbirth by about 30%. One interesting, unfortunately, named so experiment that was real life in the United States in 2010 was to forbid any induction before 39 weeks. Otherwise, this obstetrician would not be paid by the insurance. And of course, when money is at stake, these rules are applied very quickly, and you could see within the next 5 years, a sharp increase in the rate of term stillbirth. So we need to apply for reasons. We need to consider that this society is the society of risk, and women are very demanding early in pregnancy to go into a conditional pregnancy to eliminate the main genetic problems, cytogenetics, and infection. And then once it's done, we just keep them blind from the risk, and we don't provide with enough information. So what is a low-risk woman? In Europe, at least, she should be younger than 30 years, slim, Caucasian, with a physical activity or sport, no chronic condition, no gynae problem, including those you cannot diagnose, no addiction, living in a couple with a stable employment, having a spontaneous, at least second pregnancy, and this pregnancy should be planned. All right. How can you ascertain that any woman you got in front of you is actually fulfilling this criteria? You cannot, because we don't have tests to test all this accurately. So even if you consider those low-risk women, if you offer them induction of labor between 39 and 39 plus 4 days, compared to, very importantly, expectancy, not comparing women that you induce to women that are in spontaneous labor. These have been the source of a misunderstanding for 20 years, putting the blame on induction, because we were comparing induction for usually abnormal pregnancies with maternal pathology or fetal pathology, and we were comparing this with spontaneous labor. Of course, that cannot be compared fairly. The fair comparison is what has been done in the ARRIVE study 5 years ago. You compare induction of labor at 39 plus 4 without any identified problem in the mother or the fetus. You compare them to expectancy and see what happens. And then the results were a decrease in the need for a cesarean section without any additional morbidity for the mother or the newborn. Then there was this meta-analysis relying on even more cases to apprehend the situations that were needing a much bigger population. And again, it was confirmed that there was a lower risk of cesarean delivery, of maternal peripartum infection, and less perinatal adverse outcomes, including respiratory morbidity, even the so-called transient respiratory morbidity that has been put as a blame on induction, intensive care unit admission, and mortality. And indeed, if you look at the Sacred Cochrane Library that 2 years ago took all this, 34 studies worldwide with a very little heterogeneity for once, and they found a reduction from 3 to 0.4 perinatal death per 1,000 births with induction at 39 weeks. This is a huge reduction, nearly tenfold, compared with expectant management, not spontaneous labor. And then there are studies emerging recently, opportunistic studies, one of them from the Netherlands, with a very respectable name as an epidemiologist in perinatal medicine, Ben Moll, suggesting that children at the age of 12 or 16 were doing much better after spontaneous labor than after induction at 39 weeks. Why on earth, again, falling into this trap The comparison is not with spontaneous labor. The comparison is with induction and expectancy, not spontaneous labor. And also, you need to really control for other factors. And that was the JAMA Pediatrics paper from Australia did. They compared again elective birth at 39 weeks, and it was not, when it was compared to expectancy, it was not associated with childhood developmental vulnerability. Those children were as fit physically and intellectually as those that were born from a continuing pregnancy after 39 weeks, still with a reduction in elective cesarean delivery, but also, and it is very important because that is another false blame you want to put on obstetricians, which is to say that it is bad to be delivered by cesarean section. Well, they had a third group of comparison here that were elective cesarean delivery at 39 weeks, and it was exactly the same outcome for children up to 6 years old of age. So stop fulfilling women with wrong information. Fake news is the thing nowadays, but we should not play with this. And one interesting article, nearly 800,000 births between 1987 and 94. And look at the gestational age in completed weeks at which these babies were delivered and what is their performance, intellectual performance at the age of 16. Then everyone is on the same step here, culminating at 39 weeks. International Journal of Epidemiology, 10 years ago. Finally, organization is important. Organization in busy families, busy women, families that are all over the place and need to gather at the time of birth is an issue, a personal issue that needs to be respected. But also, we cannot ensure these women that they're going to deliver at the right place whenever they go into spontaneous labor. It happens in big cities, happens in Barcelona, happens in the UK. We have to take that into account. We need to organize things for things to run smoothly, and especially so if it is not done at the expense of the health of the women and their babies, but for the better, as it is with induction at 39 weeks. So let's share fairly information, including the risk of stillbirth with women. Tell them that it is safe, it is demonstrated that it is safe obstetrically with a lesser risk of cesarean section if you're induced at 39 to 39 plus 4 compared to expectancy after that. And even if you need a cesarean section that is your wish because you don't want to deliver vaginally, this is just as safe at 39 weeks. And don't listen to the tales that have been said about huge registries from 20 years ago showing some mild increase in asthma when you don't even know if those mothers were smokers or not. The current knowledge is that it is safe to deliver it between 39 and 39 plus 4, whether it is vaginally after induction with a lesser risk of cesarean section or by elective cesarean section, if it is what you wish. And I thank you for your attention.
Thank you, Yves, for that beautiful presentation of the problem. And then now I will go to Gerard Visser. As you know, Professor Gerard Visser is in fact not for and against. He will give us his own vision. Gerard Visser is Emeritus Professor of Obstetrics and Gynecology and at the Department of OBGYN and Neonatology of the University Medical Center of Utrecht. He's member and past chair of the FICO Committee on Safe Motherhood, Childbirth and PPH, and past president of the European Association of Perinatal Medicine, Research Fetal Neurology, Development, Asphyxia, Fetal Growth Restriction, Diabetes, CES section, and so on, with a huge number, more than 46,000 citations, and a Hirsch index of 99. Gerard, you have the microphone, and we will go later on to the discussion between our participants, and also between yourself. Please.
Thank you very much, Andrea, and thank you very much, Yves, for this presentation with so many beautiful paintings and sculpture. I've really enjoyed it. So is it time for a change? Induction of labor for all at 39 weeks? Well, if you want to hear my opinion, for the time, not. At least not yet. Which means we can discuss some aspects, but now it's a little bit early to do that, in my opinion. Let's remove paintings of on. Okay. There we are. Well, there is something beautiful in the physiology of the onset of labor. It has been extensively studied over the last 30, 40 years, and it is mainly is the onset of spontaneous labor. It is related to fetal maturation. The fetus generally determines the timing of delivery by indicating, okay, now it's ready, I'm ready for it, and then usually labor starts. The mother has also an effect, but since she determines the timing of the day through her circadian rhythm, most spontaneous labors will start when the mothers, and also in the whole animal kingdom, feel safest, and that's at night. So that is indeed a consequence of physiology that most labors start at night. This timing of the onset of spontaneous labor is affected by internal factors, fetal growth restriction, it's earlier, infections, it's earlier, stress by the mother, it's earlier. So this is a very nice developed system. It's a delicate and complicated system, and usually it works well. But if it fails, if the risk of continuation of pregnancy exceeds that of intervention, there is a doctor to induce labor. So far, all well, in my opinion. There is also logic behind induction of labor, almost a term. So, because when you induce labor, the fetus cannot die antenatally anymore. Still can die during labor, but antenatal period has been ended, so it cannot die antenatally. So you're likely to reduce antenatal death. But we have to make a prerequisite. Since in our world, perinatal mortality is very low, which indicates that reducing it further is not easy. And it will require quite some diagnostic and or management effect. So you have to do a lot of intervention and other things, which generally only moderate effects. Our predecessors in the past have improved outcome dramatically. And now that it is in our world so favorable general, it's very difficult to improve it even more. Here are data from all parts of the world on the stillbirth rate and the distinction between antepartum stillbirths and intrapartum stillbirths. If you look worldwide, 50% of the stillbirths are due to an intrapartum period of time. And if you look at Southern Asia, Sub-Saharan Africa, you can see it's even more than half. So in those countries, they should focus on intrapartum stillbirths. In our world, here on the left side, you can see that intrapartum fetal death is very low. So if we want to further improve outcome, we should tackle antepartum death. It's also very low, probably around 3 per 1,000 altogether, but that's the place to be if you want to further improve perinatal mortality. If you look at inductions of labor, the largest effect can be expected in risk pregnancies. I'll give some examples, but also Professor Ville indicated the obese women, the other women, the gestational diabetes, the whatever it is. So it is possible to make a certain risk assessment. And I've added here a few, and there are many more to add to this: fetal growth restriction, maternal diabetes, maternal hypertensive disorders, both for the mother and the fetus, and maternal obesity. So, for instance, let's go to being small for gestational age, risk of intrauterine fetal death in the United States, and you can see if the weight, at least at birth, it was below the 2.3 percentile. You can see that from 24 weeks onwards, there is a higher mortality in that group, with a rather sharp rise in mortality after 37 weeks. And that's one of the reasons that in case the fetus is expected to have a weight below the 3rd centile, 2.3 centile, then many of us induce labor around that period of time. 3 to 5, 5 to 10 centile, and the control group with a weight above the 10 centile. In this group, the difference is not very large. However, for us, it is not that easy to identify the really small one, since our prediction of small for gestation rates is rather poor. So the biggest problem with this slide, in my opinion, is how to diagnose exactly, how to assess exactly fetal weight. So you can, if the fetus is very small, induce labor. And I think that's a real good option. But if you look at the Dutch Digitat study, women after 37 weeks of gestation, fetus was expected to have a weight below the 10th centile. Half of them were induced, and the other half was an expected management. And you can see there is no perinatal death in the whole group, and also follow-up data and school performance, etc., were similar between two groups. One may argue that 600 women is not a large study in that field, but it indicates most likely that if the fetus has been identified as at risk, I think that's essential in the digital study, then expected management with also careful assessment of the fetal condition can also be done, and induction of labor is not necessary. Beautiful study from Sweden from last December, 300,000 deliveries in nulliparous women between 2005 and 2027. If the maternal BMI is over 30, 39 weeks, 32 weeks of gestation, you can see that in these women with a BMI over 30, there is a rapid increase in perinatal mortality. And especially if you look here at the end, it's 41 weeks of gestation. It's about 5-6 times higher than it is here. These are the mothers with a weight in between the 10, below 25 BMI. So definitely there is a risk factor with an increase in mortality if you would wait. However, it will be more intelligent, same what we do with also with assessment of fetal anomalies or risk assessment for preeclampsia in early gestation, to combine the risk factors. Study from Norway, if the fetus is small, then the odds ratio for third trimester stillbirth is 7. But independently from that, if maternal age is more than 35, it is also ratio 4, BMI over 25, it is 4, education of less than 10 years, it is 3, all independent risk factors. But if you combine them, for instance, if the baby is small, but the mother has a BMI over 25, then the odds ratio is now in this time 71. This is a univariate analysis because data were restricted, but if you look at the range, you may even see it is 14 at time because that's the lowest what it is more likely. So we should become more intelligent and weigh the different risk factors. It's not one, there might be more. And if you assess all of them, then you're much better in predicting the risk. In a way, this is logic. That if you're small and your mother is obese, that your risk of dying is much higher, because obese women usually get also bigger babies. Look at the association between maternal weight and fetal birth weight. So if the mother is obese and the fetus has a weight below the 10th centile, for that particular woman, that is a very small fetus comparable maybe to a baby with a weight around the 2.3 percentile if the mother would have a normal weight. So combine risk factors. And then let's go to the study that started it all, the ARRIVE study. 6,000 women induced either at 39 weeks of gestation or managed with expected management. Composite adverse outcome, not significant. There is one in, although there is a p-value that is just significant. Lower incidence of preeclampsia with induction and a lower rate of cesarean section, although the overall cesarean section rate is very high for nulliparous low-risk women who are at term. 18%. If nothing is wrong with you, I don't know what is wrong with the doctors at that time. If you look at more in detail, composite perinatal outcome, p-value 0.9. If you look at some specific items, perinatal death, induction group 3, expected management group, induction group 2, expected management group 3. So according to this study, you have to induce 3,000 women to prevent one perinatal death. Other items were not significant, but they are of significance. If you look at seizures, no significant difference, but it was 11 as compared to 4. Another disease, meconium aspiration syndrome, not significant, but 17 as compared to 26. And we know that meconium aspiration syndrome is a very dangerous situation. So if you look at induction, 39 weeks of gestation in low-risk nulliparous women, there are effects on perinatal outcome, but they're only small. And then in the past, there have many trials on induction of labor at around term. Unfortunately, they all started induction at different ages. And altogether, there were 4 here, there, and there that compared 39 weeks with expected management. But there was one that waited till 41 weeks, more than 41 weeks, etc. Altogether about 13. Yves also showed a slide on the Cochrane database. This is the database of 2018. And if you look at antepartum, if you look at stillbirths, and that part of the screen, I cannot see it on my here on my screen. But I think that if you would induce everyone around term, then you might prevent one stillbirth in around 1,000 women. This is the Dutch study. Show marginal effects, but still of significance. Induction of 41 weeks as compared to expected management at 42 weeks of gestation, 1,800, 900 in each arm. And you can see that in the induction group, not everyone was induced because some of them already delivered spontaneously, whereas in the spontaneous group, at the end also 26% were induced. That is the logic. If you look at the difference in gestational age, with the induction group, the proportion of undelivered women at 41 weeks, it was 50%, which is only 2 days earlier than if you would wait spontaneously. So you induce many, but overall the difference in gestational age is not large. Still, like with the ARRIVE study, composite adverse perinatal outcome is significantly different. Stillbirth not, but here also the difference is 1 as compared to 2. So you have to induce 1,000 to prevent 1 perinatal death. Neonatal intensive care, not significant, but a slight difference. Meconium aspiration syndrome, not significant, 0 as compared to 2, but this is a significant disease. So yes, 41 weeks, there are slight differences. So induction of labor around term is associated with a slight decrease in perinatal and maternal complications, with no effect on the overall on the cesarean section rate. The effects are likely to be greater with increasing gestational age, in other words, after 41 weeks, because all risk increase at the later gestational ages. But if you would induce everyone at 39 weeks, that might be at the cost of logistic labor ward problems. Yves just said that if you plan, it's much better. But what would happen if you would induce everyone at 31 weeks? Would you start with everyone at 8 o'clock in the morning? Then you would have 10 women at the same time. You don't have that many labor wards. Or should you ask half of them to come in the afternoon and then the other half at 3 o'clock in the morning or at midnight or whatever it is? That would be a possibility, but I don't think that the women might like that. They would also be longer in hospital because they're in hospital from the onset of induction of labor, and otherwise they might arrive at 4 or 5 centimeters of dilatation. So they will occupy the bed longer than if you would wait for a spontaneous delivery. There might well be a reduced patient satisfaction. Most studies show an increase in neonatal hyperbilirubinemia. Some studies show an increase in postpartum hemorrhage. There is a reduction in the women who are giving breastfeeding. And according to a French study, there is more post-traumatic distress syndrome. So we should not rely only, in fact, on this 39-week ARRIVE study from the Americans. Maybe the data are not that relevant for Europe. And therefore, we should be happy with the French who've started their own ARRIVE study, induction of labor at 39 weeks, as compared to expected management. So the French are not sure whether it's helpful, so they started their own trial, and I'm very happy with that. But then there were these terrible articles of commentaries in the Lancet. Apparently, the French midwives hated that there will now be a trial in France where they do induction of labor at 39 weeks. The French arrive a serious evidence-free and false accusation of unethical research, they comment. And there was a commentary by the Lancet themselves, they talking about the French arrive, "Elle accusant," they accuse, which is a terrible word or a word of sentence to use in France, which relates to the Dreyfus period of time, etc. But I read it, and I don't agree with what they've written, because this is the reply of the investigator. Contrary to the fact-free accusation made against us, we are particularly concerned about the implementation of a policy proposing routine labor induction for low-risk nulliparous women at 39 weeks or more, particularly because we have shown that induction of labor, a medical reason that is an independent risk factor for post-traumatic stress disorder 2 months after vaginal birth. So probably the French want to see if this is also the case with induction of everyone for 39 weeks. But it's very good that now they will do the study. We'll have to wait for the results of the study. Not yet. So we need the French ARRIVE study. Then there's another aspect. If you look at the ARRIVE trial, the UK 35-39 trial, if you look to the Swedish trial, induction at 41 weeks, if you look to the Dutch index trial, induction at 41 weeks of gestation, you can see that around 75% of women refused randomization. So most women do not want to take part of it. And from the Dutch study, we know that more than 80% refused because they did not want to be induced. So are women really waiting for an induction at 39 weeks? Let us await the results of the French trial, and let us hope they will also look at that. If you look at cost effectiveness for the Swedish study and for the Dutch study, induction at 41 weeks. Yes, for nulliparous women, it is cost effective. For multiparous women, no. So that includes almost half of the women where there is no benefit in that aspect. I think this initiative of this 39 weeks induction of labor might well be doctors driven. And the aspect is convenience. Doctors, especially those in private practice, have to deliver the patient themselves, because that's the reason the patient goes to the doctor. I want you to deliver my baby. But doctors are busy. They have many other things to do. So planning of an elective cesarean section or induction of labor is very convenient. You put them all together, 39 plus 34 weeks, so you'll have 4 inductions every 2 weeks, and you can manage that. You did all this time on 1 day instead of that. This is one of the major reasons why now in Egypt, the cesarean section rate is 72%. Because these doctors are so busy with what they ought to do, they cannot attend to vaginal delivery at night because they're too busy with other items. I don't think this is an ethical way of organizing life. You made a mess out of your life. You're too busy. And now you're going to induce everyone of those cesarean section in all your patients, because otherwise you don't survive. Alternative that we have in the north of Europe, Scandinavia and the Netherlands, do all the antenatal visits yourself. For patients, it's very important that if they come in next time, that the doctor knows their history and whatever it is. And for the delivery, let them be delivered by the doctors who are in duty call. They're there all night, and even better, by the midwife, in my opinion. So we're more or less at the end. Induction of labor around term is a realistic option in women with risk factors. We're now living in a time of individualized medicine. So why should we induce everyone? There are many factors that can be used to assess individual risk and to see if the risk is indeed 1 in 1,000 or 1 in 5,000 in one patient, or maybe 1 in 20 in another one. It's a realistic option in women with risk factors. In low-risk women, minor improvements in outcome have to be weighed against emotional and logistic drawbacks. And now I completely with what Yves said, probably in the first minute of his presentation, the maternal choice prevails. Though the opinion of the woman should be decisive after objective information. Because there are some pros, there are some items against it. And so if the doctor does not really know, please ask the women. In case of induction, do it properly, prevent hyperstimulation, etc. And do also a proper induction of labor. Because I know the literature, randomized trial on induction versus spontaneous labor, and then there is a lower incidence of cesarean section in the induction. But these are all randomized trials in centers of excellence who are motivated to do large trials. And I know already for sure what will happen in certain countries, also in Europe. They do an induction from 8 in the morning till midday and say, it's now 12 o'clock and nothing has changed. We will better do a cesarean section. So I'm very much afraid that the real world might be less favorable than the data from the Cochrane database. Finally, 2 slides from the Netherlands. In the Netherlands, we had, in the early 2000s, a rather high fetal death rate, yellow line. This is the Netherlands, this is Eastern Europe, this is Western Europe, and lowest is Scandinavia. We had a rather expected management. We didn't intervene too much, we just let things over to nature and whatever it is. And that was not a good job. So people woke up There was an increasing induction rate, not in everyone, but almost 30%, I think, of the population. Cesarean section rate did not increase. Maternal mortality fell to incredibly low values. And you can see that nowadays, the fetal death rate, we're at the level of Scandinavia. So we brought it considerably down without inducing everyone, but more aware of risk. Was this decrease in fetal death rate due to higher induction rate? I think it plays a definite role, but the other aspect is maternal awareness. It's awareness of the doctor. If you consider everyone to be normal physiologic, then you'll make a mistake. You always have to be aware. And if there are risk factors, yes, use. I'm a fetus in the womb. I fear it may become my tomb. If only I could give a shout to get my doctor to get me out. Thank you very much for your attention.
Thank you, Gerard. Thank you. Okay, then in fact, you are not no, but you are not yet. And I have found if you can close your sharing of your screen, we can have the trees. And then I have in fact seen that you agree that you have to take a particular attention to women with a greater risk. But nowadays, the women with a greater risk, if you put the maternal age, in Italy, for example, the age of first child is nearly to 32 years. And the number of children per family is 1.2, more or less nothing. And then if you take out all the women at risk and risk for age, risk for what that was Yves was mentioning, for a series of several diseases who touch the metabolism, such as polycystic ovary, or who touch the inflammation, such as the endometriosis, or who touch the structure of the uterus, you touch the myoma. And if you put all together, all this one, you know, your attitude is approaching to that Yves was telling us. Then I would like that both of you, I will go to the questions, but I would like first to start that both of you make a special question to the other partner. Start? No? Oh, yes, yes.
I've forgotten it. But may I first reply to you?
Yes.
Because what you said is more or less the same what Yves said. So I hope you're not biased towards induction of 39 weeks. I don't know if you have children who might be pregnant at this moment, but anyway.
He's convinced. No. He has been convinced by the talk, not biased.
Yes.
No, but let's say, yes, I also think if there are risk factors, and I don't think that it's almost everyone, you're exaggerating that, but then it is a risk assessment. If there are still many low risk factors, the average age of the first child, like in my country, I think it is 31 years, then at least half of them will be below 31 years of this age. So there are enough who are still low risk, not obese, no hypertension, whatever it is. And then you individualize. Why in 2023 lump everyone together instead of saying, no, it's you, yes. I definitely would advise that we now induce labor and we don't wait anymore. And then someone else who's completely happy said, can I continue? Said, yes, there's nothing wrong with you. Your risks are very low. If you want to have the absolute figures, we will also give. Anyway, the questions. I forgot to give you a question, I think.
Then I will start with a question arising from the floor, which is from an anonymous, but which is an important question. The question is that one, factors influencing the decision for timing of induction of labor, the date of the last menstrual period, ultrasound very early, serial ultrasound, no complication, and so on, fetal growth restriction. Then I think the first point is the date of the last menstrual period and how we can manage if with very early ultrasound to have a decision. But this can do if you are at the time. But if you are not and the patient is not, can be quite confused, what is your attitude? Yves.
Oh, I think CRL is the I mean, there is a consensus at least on that, is that CRL is the best way to take the pregnancy. That's consensual. Not LMP. LMP has showed that it's very uncertain. However, if you have a discrepancy of more than a week between the CRL and the LMP, you should think potentially of early growth restriction, and you should be very careful with this fetus. But it always goes the same way. If you got a smaller CRL than what is expected with LMP, with a difference of more than a week, you should be worried that it could be early IUGR. And that is a very beautiful paper I showed from published in the New England by the team from Cambridge.
And
Never rely on the last menstrual period only. Sometimes you have to, because women come very late. But yes, sometimes they made a mistake, and then you have the CRL to correct the error if made.
yes, and then another question, is this is related to the weight changing in according to the habit, according to the individual, weight changing during pregnancy. We have people who take very small weight, but we have also women who have an hyperinsulinemia, who develop gestational diabetes mellitus and so on. Do you believe, Gerard, that the gestational diabetes mellitus is an indication to anticipate the induction of labor?
Yes, but let's say in the uncomplicated gestation diabetes, that if you check all the blood glucose values, fetal weight is normal amount of amniotic fluid, I would wait until 40 weeks gestation before inducing them. However, if the baby is big, if they're not well controlled, if the gestation diabetes is only being discovered rather late in pregnancy, then, or if the baby is large, I would induce them earlier and consider them like a type 2 diabetic.
And Yves, what is your attitude for this kind of patients?
Oh yeah, especially for those. If I'm in favor of inducing everyone, I'm very much in favor of inducing gestational diabetes, but I'm just as worried when this fetus is below the 50th percentile. I'm just as worried when it is over the 80th, because if it's true, gestational diabetes being below the 50th centile, to me, is quite suspicious.
Then you have to we need a greater attention. Then, okay. Then one other question this is from Mohammed Abushal. All what I wrote above is only a comment, and I thank the speakers to share their expert experience at this statement. Cesarean section rate is highly increasing with subsequent maternal morbidities and mortalities. All right, I would like to have your point of view on that last part of the question. Is the morbidity and mortality induced by C-section? This is something who is changing according to the fact if it is an emergency C-section or if it's an already plain C-section. What is your vision about that one, Gerard?
Shall I start a new presentation?
No. Yeah, just to give an answer, Mohammed wants to.
Well, I think it is very worrying, this increase in cesarean section rate. First of all, the motivation, it's only doctors driven, or mostly doctors driven because of convenience, of money, or whatever it is. And secondly, yes, there is an increase in direct maternal morbidity, even in highly developed countries. A huge study from Canada has shown that. In the low middle income countries, there is an increase in mortality and whatever it comes with that. There are the problems of the subsequent pregnancy, from the rupture, from the placenta increta, from a higher incidence of preterm delivery. In the Netherlands, we note there was the term breech trial in Canada. So we also in the Netherlands started to do more cesarean section in term breaches. What happened in the subsequent pregnancy? There were twice as many preterm deliveries in these women. So you may help it in the first pregnancy, but all the benefits are lost in the second pregnancy. That's one. Then there is a new disease, which is what is it called? The niche. And Andrea, probably you know more about the niche than I do. Now there are niche specialists, and all the infertility doctors and the gynecologists do operations on the niche, whatever. Because almost 40–50% of these women have some problem on the inner side of the uterus, and they have bleeding and whatever it is. So we develop new diseases that were not there beforehand. But indeed, if you look at the placenta in Crete and the consequences of that, in Egypt, there is now an increasing maternal mortality due to the complications of a cesarean section. And in the United States, it also has to be found one of the risk factors for mortality. Then last but not least, Yves indicated, well, there might be a few with a little bit of asthma and things like that. Well, let's say these are about 20 observational studies, large data, all indicating there is a 20% higher incidence of asthma in later life. There is a similar increase in type 1 diabetes, also immunological disease. And if you look at obesity in offspring, it's also 20–30% higher after birth, after a cesarean section. It might well be that they still can go to the university at the age of 18, what Yves showed, but there are many other aspects in life that determine whether or not you're healthy or not. So cesarean section, if necessary, yes, please, but let's not be too easy in doing that.
Yves, what is your...
Yeah, it's good because you get two debates for the price of one. If I start from the last argument, those very huge population studies Gerard is alluding to, there are registries from admin data, mainly from the States, hundreds of thousands of cesarean section. You know that of the context. Obese children are more often in families with obese women. Obese women are more often having a cesarean section than a vaginal delivery. This is for one. And then you have no context. So I'm as a reviewer and an editor, I'm struggling against those studies that are huge. So they get respect for their size, but they have nothing useful in there. You don't know if these women with children with asthma were smokers. You don't know why the cesarean section has been performed. And certainly when you look at those studies with 100,000 of cases, was not induction at 39 weeks. This was not elective cesarean section. Mostly in the whole world, this was for a maternal or a fetal indication, which is never accounted for seriously to explain the morbidity in the children, never. Then if I move back, let me see, yeah, morbidity, placenta accreta, niche is a doctor's disease, not a uterine disease. It's a different thing. But if you look at the morbidity, yeah, the morbidity of the next cesarean section is the one that counts. So better have a good reason to do the first one. But a good reason could be medical, or it could be a strong wish of the women. And then the important question before the first cesarean section, if it's an elective one, is to say, well, how many children do you want to have? If she says 5 or 6 because I live in Cairo, then stay away from the cesarean section. If she's in Italy or in France or in Germany, where it's 1.8, 1.5, and 1.2 respectively, the number of children, if you don't want to damage your pelvic floor at the age of 45, and if you want to have a cesarean section, you're welcome. Because there are huge studies, mainly from Scotland, beautiful studies showing that the risk of an elective cesarean section is the same as the one of of vaginal delivery. These are very nice studies from 20 years ago, are valid. And also, if you take the bridge story, well, I'm surprised with the preterm delivery because there is indeed a risk of preterm delivery after cesarean section, but only significant if you were doing a cesarean section at full dilatation of the that's where you cut the cervix and it is associated with a risk of preterm delivery. not with an elective cesarean section at term. So this risk, I think, is anecdotal because the correlation is with cesarean section during labor. And therefore, there is no doubt that among cesarean sections, a cesarean section that is elective is much less a problem for the woman at the time and for the next pregnancy than a cesarean section, a crash cesarean section at second stage of labor that does not progress, for sure. And finally, if you really, what counts is really what this woman that you are discussing with is informed. We should not have, midwife and some obstetrician feel, and some midwives, not all midwives, but many midwives, because that's what they learn from midwives and from obstetricians who had certainties. They think they know the truth. They think they know what is a normal pregnancy, how a woman should deliver, when she should deliver. And they don't, when I say fair information, is to share the literature. The literature is clear that there is no added morbidity unless cesarean section with induction. Well, if you get doctors who are crooks and do not do their work properly, it's a different issue. We should assume that as doctors, we do our job properly. And when it is done properly, it's not excellence, it's just be honest and do an honest induction. If you look at my figures, I mean, the figures of my center, we started offering induction at 39 weeks, which means that 60% of women take the offer. The other 40% do not want to be induced, and that's fine. But those who take the offer, we've decreased the cesarean section rate by 20% in this. So we are down to 11% in this group compared to the 16% we had before in this group. The duration of labor is on average 4 hours less after induction. And the ripening of the cervix, they do that at home. We put a Foley catheter the night before, they go home, and they come back at 6:30 for some of them, and at 11 o'clock in the evening for the others. Those who want to have the whole family with them, they can, it's better at night, and that's fine with us. So you have two shifts of induction, 6:30 in the morning, 11 at, not 3 o'clock at night, 11 at night, you start the thing. And on average, 6-7 hours later, the baby's there. So yeah, I mean, it is realistic to implement this. It is an organization issue, but the organization, it's not only by crook doctors who want to sleep at night. It's women and their husband who is working because life is hard in big cities. And sometimes it's easier that everything happens when everyone can arrange to be there and not as a surprise, rupturing the membranes with the taxi driver refusing to take you to the hospital and that kind of stuff. So yeah, it could be cool, and it has to be cool.
Dear friends, is something interesting. We are now speaking our webinars for a huge series of people living in different parts of the world. One of our speakers live in a fantastic, well-organized country, small size, good approach to the hospital. Gerard, Dutch groups of obstetrician, they're very concerned, very attentive, they follow the rules, they are quite educated by Gerard and its groups. In the other
contrast,
side, yes, this is my impression coming to Holland and having a Dutch wife, and which she managed the house. And in the other side, Ville is living in a very confused cities, very complicated approach in Paris. The circulation is terrible, but he have organized and he is close to the French women and the French education. Then the woman have that centrality in the society, and the woman, they are the French women that are also a lot taking care of herself, and they want to have the pregnancy as much natural as possible. And he educated them to the greater risk of loss of fetuses in the late part of the pregnancy. He also living in a country where high-risk pregnancy is also increasing, as also in Holland, as everywhere in the world. then these are two fantastic conditions. But all around the world is different. All around the world is more complicated. All around the world, the number of obstetricians, the number of midwives is not so well distributed and present, and probably also their education is not at so high level. But the country's possibilities are different. Then I would like now to make a question to both of you. If you can have the possibility to teach and to speak as today to all our different gynecologists and obstetricians living either in Central Africa or living in East Asia, living also in United States or living in South America, what it should be your more important suggestion to try to reduce the terrible impact of stillbirth or intrapartum birth, that stillbirth or intrapartum death, but also postnatal death. I would like to have that comment as expert, each one of you. Who rise, Yves, and then Gerard.
Well, I think to me, that's the main point about suppressing the last wagon of this train. It's because it is more frequent and even more unbearable to lose a child after 37 weeks. It is because despite living in a country when you offer a third trimester scan to all women, at least one, most often two, we are unable, you have to be humble, we are unable to diagnose late IUGR properly. And therefore, we don't know if you are driving with your reservoir close to zero, because once you reach 38 weeks, you are close to zero anyway, but there will be no other warning. The Doppler are not going to be abnormal. The story of feeling the baby moving is a nice story, not for all women to become hysterical, but it does not tell you the baby is not going to be dead the next day. So because it is not detrimental obstetrically to the women nor to the children, that is the main reason for us to offer, not impose,
yes.
offer induction at 39 weeks.
Gerard.
Well, I think especially in low-income countries, they are still very far away from an induction at 39 weeks. What do we need in healthcare and obstetrical healthcare? It is basic facilities, roads, hygiene, blood transfusions, safe operations, etc. That's what they need. Unfortunately, many of the doctors want the most modern ultrasound machines, but part of the time they even cannot use that because there is no electricity. So basic facilities. If there is something wrong, if you're in a rural area, there should be transport to a regional hospital, to a larger hospital. Those logistic reasons are the most important. If we look at maternal mortality in Europe, let's say around 1920, it was about 500 per 100,000 women. Then in the next 20 years, it came down from 500 to 20 per 100,000. Only by introducing basic facilities, blood transfusions, antibiotic, very important. And now, if you look at the low-income countries, they still have a perinatal mortality, a maternal mortality of 500 per 500,000, what we had 70 years ago. I think also what they need is the basic the facility. And later on, when they brought down their maternal and perinatal impaired outcomes, then you may think about Dopplers or induction of labor, whatever it is. And I agree with Yves, what he said about the estimation of the duration of gestational age. That's essential. If you don't have that in the low-income countries, then I'm sure that 70% of your induction of labor at so-called 39 weeks will not be at 39 weeks, but half might be considerable earlier than that. So please have your basic system in order, and then you may have the option of inducing them at 39 weeks of gestation.
Thank you. And then I would like to make also a comment on a point that Yves rose at the beginning of his presentation, that the placental age can be can have a different evolution in comparison to the fetal age. And then the life in the present world, I don't know, probably the quality of the air, the quality of the food, the stress, the late moment of pregnancy, touch also the potential biology and the potential protective effect and fundamental effect for the fetal metabolism that is placenta. This also we have to think about. Dear friends, I don't know, it was a fantastic event. It's not a webinar where each one is speaking. It was a fantastic comparison of two masters full of love for their patient, for the obstetrics, for the fetuses who have the chance to be followed by you. And then I would like to thank all of you of being with us. And it was for us a fantastic event. And since that, thank you, Gerard. Thank you, Yves. And Yves, take care of my daughter, Sarah, who have to deliver. This is the fact. But Gerard is part of my family as I have a Dutch wife.
So next debate on cesarean section, I hope, because there were many things that were not completely correct indicated by my opponent. So I'd rather have a second go.
Then I want to thank you very much for your help today, and invite all our followers who are still all there to the next session, which will be also on a very attractive topics and very important, is the management of menopause in breast cancer survivors. We will have Edward mentioned and Camille Castelo Branco. And I invite all of you of being with us the 4th of July. And also I invite all of you in Amsterdam to our 15th Congress of the European Society of Gynecology, where also Professor Ville and Professor Visser will be present, and will be from the 29th to the 2nd of December this year. Thank you, and enjoy your life. Take care of yourself, take care of your patients, and also take care of their pregnancy. They are precious, precious, precious. Thank you, Yves. Thank you, Gerard. Have a good day. Au revoir.
Bye-bye.
Bye-bye.